Hello and welcome once again. Africa has so far defied dire predictions to survive the deadly COVID-19 pandemic. The question is, why? Well, a new study by a consortium of African medical doctors has given reasons the COVID-19 pandemic appeared not to have had the catastrophic effect on the health indices in most African countries as earlier predicted. Factors such as low population density in cities and communities, large young population, previous experience in epidemic control, and effects of medication used for related diseases in the past were said to have produced the success, or rather the success rate, some African countries have recorded so far. The findings were contained in a 2020 research journal published by the Nigerian Medical Association, NMA. This is the first comprehensive research by African Medical Scientific Research Team to offer scientific explanation, while the continent seems to have largely escaped doomsday predictions. Before the publication of the research findings, Western countries have been baffled why Africa, with its weak healthcare infrastructure, was spared the devastation the COVID-19 wrought on the West. Now let's take a look at the report. First, African countries with highest number of reported cases and deaths.
See from the graph on the screen now, this graph is showing African countries with the highest number of reported cases and deaths. So let's start with South Africa. South Africa has 53% of the total cases of COVID-19 on the African continent and 41% of the total number of deaths. Egypt 10% and then 24% of the total number of deaths. Nigeria is shown on the graph as well, representing 5% of the total cases on the African continent and 4% of the total number of deaths. And Ghana, Algeria also represented, followed by others representing 25% of the total number of cases and 24% of the total number of deaths. What's interesting is this report has attributed quite a few factors as to why we can see the statistics that we are seeing up on the screen right now. For example, South Africa and Egypt have more international flights coming in and out of their airports, far busier airports, than other countries on the African continent, probably with the exception of Ethiopia and Kenya. But their airports are used more as transit airports, not necessarily people coming into the country. Other reasons that were given, of course, have to do with countries like Nigeria having battled past epidemics like Ebola, so having that experience too.
Yes, indeed, having that experience. Another thing that was factored in was the fact that they seem to have got immunity from the past experiences like Ebola, which you mentioned. Let's look at the world now. We'll compare this with what we're having of the world, the COVID-19 cases and the mortality in percentages. You look at Asia, they have the highest number. The population is there, all in blue, 59.54. with 24% of the cases and 14 mortality. Then you get down to Africa. Africa seems to be the lowest if you watch there, except for Oceania. Africa has 70.2% of the population of the world, and then they have 5% of the cases of the entire globe, and then 3% of the mortality. Then you go to Europe, that seems to, after North America, is the highest in mortality with 30%, and the cases 16, and then they have the population, of course, is 9.59. Leila, I'll have you come in from North America rather.
I'll come in on North America in just a second. Just to comment on Africa as well. What's interesting here is that clearly Africa has defied a lot compared to tales we were told and things that we were told at the start of the pandemic. There were horrible predictions for Africa and what Africa could possibly face. And that is not what Africa has clearly gone through here.
Even from WHO, all have been proving wrong. Their predictions are falling flat on the face. Again, based on what we were talking about earlier, the question of population density, immunity, then experience from past experience. Experience they've gotten from dealing with past, like tuberculosis and then Ebola and the rest of them, and the question of immunity as well.
Absolutely. However, experts are also warning that Africa should not be complacent. While it took 6 months to get to the first 500,000 cases, it took just 2 months or under 2 months to reach the 1 million mark. Now, among the African doctors who carried out the research are Ebun El Bangboye, Jesutu Tutofumi A. Umie and also Oluwasegun J. Afolarami, all of St. Nicholas Hospital here in Lagos, Nigeria. Also included were Mogamat Razin David, Division of Nephrology at Stellenbosch University in South Africa, and Tygerberg Hospital as well in Cape Town, South Africa. Others were Elliot Koranteng Tanner of the Renal Unit's Department of Medicine at Komfo Anokie Teaching Hospital, Kumasi, Ghana. Shoyab Wadi, Wits Donald Gordon Medical Center at the University of Witwatersrand in Johannesburg, South Africa. Abdou Niang, Dalal Jam Hospital, and Dakar Sheikh A. Diop University, Senegal. There were also Anthony Were, Department of Medicine at the East African Kidney Institute, College of Health Sciences, University of Nairobi, Kenya, and also Sarala Devi Naika, Department of Internal Medicine at the Faculty of Health Sciences, University as well of Witwatersrand in Johannesburg, South Africa. Quite a number of medical experts on the African continent there.
Indeed. Let's dissect this report further now as renowned Nigerian professor of virology, Oyewale Tomori, joins us live. Professor Tomori was the regional virologist for the World Health Organization, WHO Africa region, between 1994 and 2004. Glad to have you on Newsday, Prof. Let's begin with what my colleague read out there. You'll see quite some Nigerians, and of course you have Ghanaians. I mean, it was an African thing. What's your sense of this, speaking to the fact that Africa should develop its own solutions to its own myriads, to its own problems or challenges?
Thank you very much. I'm really glad to be with you. This publication by so many people from different parts of Africa, Ghana, Kenya, South Africa, it's the right way to go. And it has proven one thing, that history has made a fool of us again. You see, the historical thing about Africa is that epidemics will occur, people will die in Africa, and all sorts of things like that. And so we're living on the historical background, and I assume that when COVID comes, it's going to cause that kind of problem. Yeah, but then it didn't show that, because COVID is different from Ebola, COVID is different from malaria, COVID is different from this thing. None of us knew anything about COVID until it started coming. And therefore, we're living on the past experience of Africa, and assuming that if it did this in Europe, then it must do worse things in Africa. And our colleagues have shown that that is not the case. Mm-hmm. Now, what are the reasons for it? And I think that is what their paper came out to give. Why didn't we have the same situation that we had in Europe and as occurred in there? Why is Africa not showing the same kind of problem that we thought we had? I think it is important for us to me, the lesson that we learn from that is not even what they are saying. The lesson we learn from that is we should not be complacent, number one. Number two, the problem is not yet over. And number three, there are so many things we still do not know about COVID that we need to continue to watch out for. Over.
Certainly, Professor, many thanks. And a very interesting mention in the report as well was the possibility that exposure to similar coronaviruses in the past may have led to cross-reactive coronavirus antibodies protecting people. What are your thoughts on this? Because haven't other continents as well also experienced previous coronaviruses?
That's fantastic speculation. In fact, there's a study already done, I think, in Tanzania, where they have shown that 15 to 20% of the people they tested, just a small number of 300, had antibodies to a related coronavirus. The coronaviruses that we know are all over the world, but there are some that are more related to each other than the other. Take, for example, the MERS-CoV in Middle East. It's a kind of coronavirus. There are other coronaviruses which cause cold and things in normal human beings. However, I think which coronavirus exists in your place determines whether you have a protection against it. But the study that they've done in Tanzania only shows that there is antibody, but does not tell us whether the antibody is protective. So there are two different things. You may have something that's related to it. You need to find out one that is protective. And so we need to do more studies, not just in Tanzania. In actual fact, there's a study being planned for Nigeria in which they are not only looking at the antibodies to the coronavirus. We are going into archival sera collected 4, 5, 6, 10 years ago. and see what antibodies exist. But go beyond that, whether these antibodies are actually protective. That's the study that will answer that question. But right now, it's a speculation, and we need to do more research than has been done in the African region.
Good. You talked about lessons learned, Professor. Let me deal with that a little bit more. What are the lessons to be learned concerning how the international community tells the stories that concern Africa?
First thing, people say we are oral tradition people. We like telling stories, but we don't like writing them down. A European will come to Nigeria, come to Lagos for 1 hour and write a textbook about coming to Nigeria. We will be in Lagos for the rest of our life and we'll be telling stories from each other. That's one thing we need to begin to tell, and tell our story as is. Whatever story those people tell is at their own. I mentioned at the beginning that I said we have been fooled by history. Everything bad is associated with Africa. And so the Bill Gates and other people who thought that they're going to be a disaster in Africa were based on their own past experience, which they have written, not that we have written. And so one big lesson, we must write more about our own problem. We must get this information out to people, not orally. Because when I tell you a story and somebody hears it the other day, it's going to be a different story he tells. And by the time it gets to the fourth person, the story has no foundation anymore. Until we write these things down, we must learn to write down like people are doing. That's the first lesson I think we need to learn. Another lesson is for our people to have confidence in their own talents. There are a lot of talented Nigerians in Africa, all Africa, talented expert researchers, who are doing great things. However, the only difference between those in diaspora and those at home is the environment. When you create the enabling environment for your talents to function, then you see that we do much better than those people are doing. We have the problem, we know our people, and we understand the situation. It's like bringing a carpenter to your house, and he has no hammer, he has no saw. What kind of carpenter is he going to be? He's as bad as you. Or bring a mechanic to come and repair your car, and he has nothing in his hand to do the repair. He's as good as my grandmother. So also, when we have talents in Africa, and our governments do not create the environment for those talents to function, then we become what we call novices. And that's what is happening to us. So we must create the environment for our talents to function. The generation that is on now is probably smarter than my generation. And a little more improvement in the environment will make a difference and much better. I'm what I am today because the environment that was created when I was growing up. And without that environment, I wouldn't be what I am. But then one other thing, that environment has so deteriorated me so that I'm an expert of yesteryears, have now become the novice of today because I don't have the environment to continue what I was doing when I was younger.
Very well said, Professor. Another interesting finding in the report is the possibility that ongoing BCG vaccinations against tuberculosis could be contributing to the low numbers that we're seeing in Africa. The report also found that countries in Europe that are carrying out BCG vaccinations at the moment do have lower numbers of coronavirus cases in their countries at the moment as well. Now, although there is no empirical evidence to support this at the moment, Professor, does this help the search for a vaccine in any way, or the race for a vaccine in any way?
Thank you very much. I'm glad you said there was no empirical data to support that. These are all speculations. And again, these are people just begin to think of what could be the reason. And so you think of all sorts of things that could lead to that. None of that BCG has shown, it's a speculation that people have raised. There have been all sorts of speculation being raised by people that if you got polio vaccine, you shouldn't have cases or something of that nature. There's no scientific basis for all those ones. The only thing we can look at is that the more your body is challenged, the more primed you are for that body to be able to protect itself against other things. And therefore, we believe that the vaccination in different areas stimulates the body's, primes the body's immune system to act whenever another person comes, another agent comes. But I don't think there's been any clear-cut relationship between either BCG or polio or any vaccination. It's all speculations.
Now, Prof, how will this report help Africa in providing or improving its health knowledge, experience, and then, of course, infrastructure? You talk about facilities.
Good. But this study, for example, has shown that, the age population in Africa, they mention in their study about the fact that the renal problem you find in other places are not here. These are information that we need to follow, to make use of, not using textbook from Europe. Now, I've had an occasion in which a textbook in Europe talked about yellow fever killing 60, 70% of the people. And I went into Liberia to go and do some work many years ago. And the expert was telling me this cannot be yellow fever because it has not killed 60% of the people. But then he forgot that if yellow fever is in your place, you will have had a lot of people with immunity. Therefore, you won't have the number of deaths. We as Africans must learn from our own experience. And we need data to be able to get that information and plan accordingly, not according to what the British or the Americans are saying. We must base our planning on the information that we have. And that's why we need to do more research. And that we are calling on our government to create that environment to do more research. Now that we know, what information that from this study that has shown some of the some of the information that is available, we can now plan better in determining how we do. Take, for example, the issue of the fear that people have about their COVID, where many people are dying in Europe and all that, but it's not dying here. How do you tailor your information to your people? They're not seeing anybody dying. They're not seeing people dying. And yet they say, oh, why are you creating all this and telling me to put on my face mask? We must tailor our information down to the individual. It is not that people are not dying. People are dying. Maybe they are not dying as much as they're dying in Europe. You could be the one of those ones that will die in Africa. So why don't you protect yourself? So instead of carrying out the information, everybody must do this, must do that, base it on the information that you have. And now I'm saying, relate that information about protection to the individual. Like I always say, the COVID is not going to kill my government. It's going to be me. I'm the one that is vulnerable. Therefore, I need to protect myself. Our information should go towards that direction, focusing on the personality and on the individual.
Thank you, Professor. Very well said. As a matter of fact, I believe it's South Africa that between mid-May and July this year saw about 17,000 strange deaths that they couldn't necessarily say what they were from. And there's been an increase in that across the continent. Now, while things, of course, are looking better for Africa, we also shouldn't be complacent. We were discussing this before you joined us on the program. It took us 6 months to reach the first 500,000 cases on the continent, but it only took us 2 months, or just under 2 months, to cross the 1 million mark. What does this tell us about the current trend of the pandemic on the African continent?
A very good point you've raised. In the first 6 months that you had that little number, our testing was not what it should be called. Over the next 2 months, of course, our testing improved and we found more cases. The cases that you find, the cases that we report as laboratories are just those ones that you tested. There are 60, 70% of people who have COVID do not show the symptoms. So I wouldn't know whether they have it until I test them. And therefore, when our testing improved, we detected the cases faster and faster. And that's why it took us a less period to get to 1 million than it took to get to 500,000. So continue to improve your testing. And then you get it better to know exactly the magnitude of your problem. And when you know the magnitude, in fact, the advantages of testing would be further. If I know I have and I'm positive, then you can quickly and rapidly isolate me so that I don't spread it to other people. And today, that you and I are going around the country in which people are no longer wearing masks, how do I know that even though I'm not showing the symptoms, I don't have COVID? And yet when I sneeze to your face or shake your hand, I'm passing the thing to you. Therefore, it is important that, because we do not know exactly how many people, because when you look at the number of people that have, you have to count the number that are positive by the laboratory, you have to count the number that are actually sick but have not been tested, you have to count the number that are sick but are not showing symptoms. So when you look at that number, what the laboratory is getting is only a tip out of the iceberg. Therefore, the more you test, the more you know what the situation is. So my advice is we continue our testing, whether we like it or not. And which brings me to the issue of whether there's going to be a second wave or not a second wave. When your data foundation is wrong, you can't even think of second wave. You don't know what you have because you didn't get the right situation in the first place. So you can't be talking of second wave. If our testing improves dramatically, I can expect there'll be a large number in what we call a second wave. But if we are testing at the rate we are testing, our level is not going to show too much signs or something, because our foundation of our data is faulty from the beginning.
So, before we let you go, Professor, let's talk about the question of complacency. Is there a danger, really, of either the people, the government, Africa generally being complacent? And if there is that danger, how do we prevent that danger? What should we be doing, being proactive to prevent that danger of complacency?
You know, one of the most, thank you very much. There's no doubt that we have been complacent in this country. And there's no doubt about that. At the government level, at the individual level, even when we locked down and all the face masks and things, I used to joke that the only person wearing a mask in my village is the masquerade. The rest of us are not wearing. And that's the problem. We must continue to get that message down to that individual. COVID is still around. It has not gone. People are still sick. People are still dying. And therefore, if you don't want to be one of the victims, please do all the 3, 4, 5 things they say you should do. Wear your mask, wash your hands, keep a safe distance. I was at a TV station a few days ago in which everybody had their mask off. And the guy there told me I should take it off. I said, no, I'm not taking out my mask. I said, because in this room where we are, with all the air conditioner blowing and the little places, I don't know whether you have the COVID. And therefore, I'm going to protect myself. So you bring that message to the individual, as I said before. Protect yourself. If you protect yourself, you protect your family, you protect others around you, you protect your neighbors. Let's bring this message down to the individual. COVID is still around, and it will be around. In fact, the way I look at it, COVID may just become part of the routine things that we do in the disease structure of our country. But it is still around, so please protect yourself. Bring that message down to me as an individual, that, I am the one and the most important component of this transmission. Therefore, protect yourself. Make sure you don't spread it on others, and make sure you don't expose yourself to get it also.
That certainly is that worry. Could COVID-19 be endemic? Professor Oyewale Tomori, many thanks for joining us on Newsday today.